Hello everyone. Today we are going to learn about the most common type of shock, that is hemorrhagic shock. So hemorrhagic shock is due to uncontrolled bleeding which lead to the formation of the hypovolemia, and it will lead to the decreased cardiac output and increase in the heart rate. So because of the hypovolemia, there is a sympathetic stimulation which causes effect on the cardiac system and on the peripheral vascular system. On the cardiac system, it causes increased heart rate, and on the peripheral vascular system, it causes vasoconstriction. So increase in the heart rate, that is the tachycardia, is the earliest sign of the shock. Say, let's see the pathophysiological and effect of the hypovolemic shock on the various system. So because of the shock, there is a tissue hypoxia. We have learned about the features of the tissue hypoxia at the cellular level in previous chapter. So at the cellular level, because of the shock, there is a cell death and the lysis of the cell, which ultimately result in the hyperkalemia, hyponatremia, hypocalcemia, and metabolic alkalosis. Metabolic acidosis. Metabolic acidosis is due to anaerobic respiration leading to the byproduct, that is lactic acid, which causes metabolic acidosis. And because of the decreased cardiac output, there is a reduced renal perfusion, which ultimately activate the renin, angiotensin and aldosterone system, which causes sodium and water retention, and it will result in the decreased urine output. So because of the shock, there is a decreased renal blood flow that ultimately lead to decreased urine output. And because of the shock, body tries to convert blood to the vital organs such as lung, liver, kidney, and towards the brain, and there is a decreased blood supply towards the skin, GIT, and the muscle. This is because of the compensatory mechanism of the body, which causes diversion of the blood from skin, muscle, and the GIT towards the more vital organ, and it will result in the splanchnic vasoconstriction. That is the vasoconstriction of the blood supply to the bowel, which ultimately result in the bowel ischemia, gangrene of the bowel, and the paralytic ileus. So this is the effect of the hemorrhagic shock in a case of a GIT. So ultimately, over a period of time, the blood supply towards the vital organ also decrease because of the continuous blood loss, will ultimately result in the decreased blood supply to the brain, which causes altered sensorium, confusion, and coma. Because of the decreased blood supply towards the lung, it will causes increase in the respiratory rate. This is also because of the compensatory respiratory alkalosis. The body tries to compensate the metabolic acidosis by increasing the respiratory rate and form the compensatory respiratory alkalosis. So these are the effect, systemic effect of the hemorrhagic shock. So let's see what are the resuscitation methods of the hemorrhagic shock. So the basically resuscitation is depend upon the if the patient is having active bleeding or patient is having no active bleeding. If the patient is having active bleeding, the control of the hemorrhage is the most important management in case of a active bleeding. If the patient is not actively bleeding, then the most important treatment would be correction of the shock state by normalizing the end organ perfusion. That is the treatment of the hypovolemia resulting in the end organ damage. So this would be the method of resuscitation depending upon the patient is having active bleeding or is having no active bleeding. So let's see the very important concept in the trauma patient, that is the trauma induced coagulopathy. In case of a hemorrhagic shock with trauma, there is a combination of trauma as well as shock. The trauma will lead to the metabolic alteration due to the release of the cytokines in the body, as well as the shock causes the endogenous coagulopathy, will result into the trauma induced coagulopathy. So let's see the pathophysiology of the trauma induced coagulopathy. So trauma or any surgery will lead to the blood loss and ultimately result in the shock. So shock causes release of the endogenous cytokines, which ultimately lead to the endogenous coagulopathy. So because of the trauma, there is an acute traumatic coagulopathy. The acute traumatic coagulopathy is characterized by three features. These are the hyperfibrinolysis, platelet dysfunction, and the low fibrinogen level. So remember the components of the acute traumatic coagulopathy, that is hyperfibrinolysis, platelet dysfunction, and low fibrinogen level. So because of the acute traumatic coagulopathy, and simultaneously we started the resuscitation because of the shock. So because of the volume overload also, there is a formation of the dilution coagulopathy, and we are giving the fluid to the patient which is at the room temperature or at the below temperature, which causes increase in the hypothermia. So the temperature loss is can be there because of the overzealous resuscitation, and if there is a need of a surgery, so during the operations there is we open the body cavity, which causes the hypothermia, that is heat loss. So dilution coagulopathy, hypothermia, and the metabolic acidosis due to shock. So this could be the death triad, that is coagulopathy, hypothermia, and metabolic acidosis. So this is known as triad of death in case of a shock. So the triad of death consists of coagulopathy, hypothermia, and the acidosis. So ultimately it will result in the trauma induced coagulopathy, which causes further bleeding and ultimately result in the death of the patient. So this is all about the trauma induced coagulopathy. So what will be how will we manage this patient with actively bleeding? So let's see the types of the hemorrhage, and we'll see the treatment of the hemorrhage, or in case of a actively bleeding patient management. So hemorrhage can be it could be a concealed hemorrhage, or it could be a revealed hemorrhage. Revealed hemorrhage is a type of external hemorrhage in which the bleeding is obvious. Example are open arterial wounds, or hematomesis, or a bleeding PR. This could be a causes of a revealed hemorrhage. But sometimes the hemorrhage is inside the body cavity, which could not be seen by the clinical examination alone. So the clinical concealed hemorrhage could be due to hemothorax, or it could be due to hemoperitoneum, or it could be due to fracture of the limb. It could be occult GI bleed also, and it will causes there could be a discrepancy between the clinical assessment and the amount of fluid loss, because of the blood loss is inside the body cavity. So another classification could be depending upon the time at which the hemorrhage occur. It could be a primary hemorrhage, or it could be a reactionary hemorrhage, or it could be a secondary hemorrhage. Primary hemorrhage is during the surgery or the immediately at the time of the trauma, and the reactionary hemorrhage is delayed type of hemorrhage which occur within 24 hours after the surgery or a trauma, and this could be due to dislodgement of the clot or due to slippage of the ligature. We tied the blood vessel during the surgery, but there could be a slippage of the ligature which result in the active bleeding. This could be due to this is a reactionary hemorrhage which occur within the 24 hours. The last one is a secondary hemorrhage. It mostly occur after 7 to 40 during the 7 to 14 days after the surgery. It could be due to, or most common cause of secondary hemorrhage is infection. So infection will lead to the erosion of the blood vessel, or it could be due to pressure necrosis due to the placement of the drain, or it could be due to malignancy. So this could be the types of the hemorrhage. It can be a primary hemorrhage, reactionary hemorrhage, or a secondary hemorrhage. And there is another type of hemorrhage that could be a surgical hemorrhage and the non-surgical hemorrhage. In surgical hemorrhage, the hemorrhage is due to active bleeding from the blood vessels, and that could be controlled by the surgery, ligation of the vessel, or could be treated by the angioembolization. And non-surgical hemorrhage is due to coagulopathy. It will be treated by the treating the coagulopathy. So this could be due this could be the classification of the hemorrhage or types of the hemorrhage. So depending upon the amount of blood loss, the hemorrhagic shock is categorized into the 4 categories, and this could be the most important chart or table in this chapter. There are many questions can be asked regarding this chapter on the basis of this chart. So the hemorrhage can be classified, or hemorrhagic shock can be classified depending upon the amount of blood loss. It could be a class 1, 2, 3 and 4. So let's see one by one. So just remember the amount of blood loss in each class. So in class 1, the amount of blood loss could be less than 15%. Class 2, the amount of blood loss could be 15 to 30%. In class 3, it is 30 to 40%. And in class 4, blood loss is more than 40%. The amount could be, in case of a class 1, the amount is less than 750 ml. In class 2, 750 to 1500 ml. In class 3, 1500 to 2000. And in class 4, it is more than 2 liters of the blood loss. So let's see the characteristic feature in the class 1. Class 1 is like a shock due to very little amount of blood loss, that is less than 15%. Usually it is like a blood donation. So in case of a class 1 shock, there could be a compensatory mechanism of the body. The amount of blood loss could be compensated by the compensatory mechanism. There is no change in the clinical parameters in the body due to class 1 shock. So the heart rate, respiratory rate, pulse pressure, blood pressure, and the mental status and the urine output, all the parameters would be a normal in case of a class 1 shock. And the base deficit could be the 0 to -2, that is at the normal level. And the class 1 shock could be treated with the just by giving oral fluid or giving some crystalloid. So let's see the class 2 shock. In class 2 shock, the amount of blood loss is above the 15%. It is the 15 to 30%. So here there is a compensation. The mild there is a compensation occur, but there is a change in the some clinical parameters in the body. These parameters are the most important parameter which changes during the shock, or could be the first initial parameter which altered during the shock is, that is heart rate. So the heart rate or tachycardia occur during the class 2 shock. So remember that there is a tachycardia during the class 2 shock, and there is a decrease in the pulse pressure. Why the pulse pressure is decreased? This is because of the compensatory mechanism. Body tries to divert the blood from skin, muscle, and the GIT towards the vital organ. This occurs because of the peripheral vasoconstriction, and peripheral vasoconstriction causes increase in the diastolic blood pressure. What is pulse pressure? Pulse pressure is systolic blood pressure minus diastolic blood pressure. So the diastolic blood pressure is increased because of the peripheral vasoconstriction. So the pulse pressure is decreased in case of a class 2 shock. Remember that there is a change in the clinical parameter in the class 2 shock. These changes are tachycardia and the decrease in the pulse pressure, and all the other parameters remain unaffected because of the compensatory mechanism. So the respiratory rate could be mildly increased, but it could be at the normal range. So there is a change of the heart rate and the pulse pressure. So, and the base deficit in the class 2 shock could be -2 to -6. So it is a compensatory shock or a mild type of shock. Type 2 shock is also called as mild type of shock, a compensatory type of shock. But remember that in type 2 shock also, the body tries to compensate the blood loss by diverting blood from the muscle, GIT and skin towards the vital organ. But at the tissue level, there is a metabolic changes which result in the metabolic acidosis. So there is a base deficit of about -2 to -6 milliequivalent. So in case of a type 2 shock also, there is a lactic acidosis present, and this could be treated by infusion of the IV crystalloid. IV crystalloids are ringer lactate solution or the normal saline. So remember, this is all about the class 2 shock. In class 3 shock, class 3 shock is also known as moderate type of shock, and class 3 and class 4 are the decompensated shock. Due to prolonged blood loss, now body has given up the compensatory mechanism because of the continuous blood loss. Now all the parameters are going to be increased. So there is an increase in the heart rate, tachycardia is there. So the respiratory rate is increased to 30 to 40 per minute. There is a decrease in the pulse pressure. The systolic, yes, the most important parameter remembered in class 3 shock, that is change in the or decrease blood pressure. So first time blood pressure is decreased in type 3 shock. So the compensatory mechanism has lost and there is a decreased systolic blood pressure. So, and the mentation is the patient is confused and there is a urine decrease in the urine output. It is up to 5 to 15 ml per hour, and the base deficit is also increased it is -6 to -10 in case of a type class 3 shock, and this could be treated by crystalloid, or there could be the possibility of requirement of a blood in case of a class 3 shock. So the treatment of a class 3 shock is crystalloids plus minus blood transfusion. So the most important clinical parameter which changes in the class 3 shock is the blood pressure. So the blood pressure is first time decrease in case of a type class 3 shock, and the class 4 shock, the blood loss is more than 2 liters. All the parameters are deranged. There is a tachycardia, pulse become feeble, and all the parameters are unrecordable. Like there is a increase in very much increase in the respiratory rate, pulse become feeble, BP become unrecordable, patient become lethargic and comatose. Then there is a anuria, presence of the anuria, the urine output is severely decreased, and the base deficit is more than minus 10 milliequivalent, and it should be treated with the crystalloid and the blood transfusion. So blood transfusion is necessary in case of a class 3 and class 4 shock. So let's see the classification depending upon the, so this is could be the most important chart in a given in the Billion law. So the class clinical features of the shock depending upon the compensatory and uncompensatory shock. So let's see the mild type of shock. The mild type of shock is a class 2 shock. Moderate is a class 3 shock, and severe is a class, yes, severe is a class 4 shock. So in case of a mild or a compensated shock, there is a presence of lactic acidosis. So we have already seen in class 2 shock also there is a mild lactic acidosis which causes the base deficit of about -2 to -6 milliequivalent. So lactic acidosis is there in the mild type of shock. Urine output is normal, conscious level is normal, respiratory rate is increase or more of a normal. So the most important feature to be remembered in mild shock is a increase in the heart rate, that is pulse rate, and the blood pressure is normal because of the compensatory mechanism. But during the compensation, the blood is diverted from skin to the vital organ, so the peripheries become cold. The peripheries are cold peripheries. Cold peripheries are seen in the mild type of shock. And let's see the moderate type of shock, in which there is a large amount of lactic acidosis, urine output is reduced, and patient become drowsy, the respiratory rate increase, pulse rate is increased, and there is a first time there is a presence of hypotension. So the decrease in the systolic blood pressure first time occur in the moderate type of shock, and moderate and severe type of shock are the types of uncompensated shock. And severe shock, that is class 4 shock, there is a profound or more than 10 -10 milliequivalent base deficit, patient become anuric, comatose, labored breathing is there, and there is a pulse rate, that is tachycardia is there, with feeble pulse, become feeble pulse, and there is a severe hypotension in case of a class 3 or a severe type of a shock. So this is the important chart given in the love and belly. So there is another important term given in the recent belly, that is occult hypoperfusion. So this is a type of a compensatory mechanism in which all the cardiovascular parameters as well as the urine output is normal, but at the tissue level there is a presence of a hypovolemic shock. This is clinically detected by the low mixed venous oxygen saturation, and there is a presence of a acidosis. So this is the term occult hypoperfusion is normal cardiovascular parameter and there is a normal urine output despite there is a low mixed venous oxygen saturation and there is a acidosis. So just see the more important features in a respective class of the shock. In class 1 shock, all the parameters are normal. In class 2 shock, this is a compensatory phase or a mild type of shock. So this is compensatory phase or there is a mild type of shock. There is a tachycardia is the earliest manifestation of the shock which is occurred in the class 2 shock. The systolic BP remain normal. In case of a class 3 shock, class 3 is a decompensated phase of the shock. The first time there is a fall in the systolic blood pressure, the patient will become confused. And class 4 shock is a severe type of decompensatory shock in which the patient becomes comatose and all vitals are not recordable. So this could be the most important chart in case of a hemorrhagic shock. So this is the most important chart in case of a hemorrhagic shock or a hypovolemic shock. So let's start with the treatment of the hemorrhagic shock. So the most important treatment in case of a hemorrhagic shock is the identification of the hemorrhage, so that we should control the hemorrhage. So in case of a shock, any shock, patient should be considered hypovolemic shock unless and until proven otherwise. So the hemorrhagic shock is the most common type of shock. Initially, the patient came with the shock before evaluation or before identification of the cause of the shock could be considered as a hypovolemic shock, and resuscitation should be started as early as possible. The hemorrhage is until the hemorrhage is excluded, it is considered as a hypovolemic shock and the resuscitation started. First, there is a protection of the airway, breathing, and the circulation, in which the large bore IV cannulas are inserted in the peripheral lines. The cannula preferred are large bore and short length, that is ideally 18 or 16 gauge. Green or grey colored cannulas are inserted for the resuscitation. So, and the control of hemorrhage is started simultaneously. It could be due to the control of hemorrhage may require surgery or can be endoscopically management of the hemorrhage, like in case of a upper GI bleed, or it can be due to controlled by the angioembolization. If there is a continuous bleeding and the patient is in shock and all the measures for controlling of the hemorrhage are failed, then there is a protocol, that is damage control resuscitation, which should be initiated. So the damage control resuscitation is also known as hemostatic resuscitation. It is a type of resuscitation which is applied only when the patient is actively bleeding. So no shock state can be corrected until the bleeding stops, and the transfusion will worsen the situation. So if the bleeding is uncontrollable, bleeding is active, and we are giving more and more amount of blood transfusion, there is a no use of that transfusion, or otherwise that increase in the blood transfusion will lead to worsening of the situation by increasing the dilutional coagulopathy, by increasing the hypothermia, and because of the increase in the metabolic acidosis, hyperkalemia, and the hypocalcemia, it will worsen the situation. So the basic principle of the hemorrhagic treatment of the hemorrhagic shock is the control of the hemorrhage. So resuscitation is simultaneously started, but there should be a control of hemorrhage as well. So basically the damage control resuscitation has a 4 key principles, which include: one is rapid hemorrhage control, then permissive hypotension, avoid dilutional coagulopathy, and last one is a treatment of a existing coagulopathy. So remember the 4 key components of the damage control resuscitation. These are the rapid hemorrhage control, permissive hypotension, avoid dilutional coagulopathy, and treatment of existing coagulopathy. So let's see the one by one. What is rapid hemorrhage control? So these are the methods by which there is a control of the bleeding. The external bleeding can be controlled by packing, or by tourniquet, or by the balloon occlusion, and the intracavitary hemorrhage can be controlled by interventional radiology technique like angioembolization, or if necessary there could be the possibility of the damage control surgery. So damage control surgery is a part of damage control resuscitation. So damage control surgery, it includes the arrest of the hemorrhage, control of the sepsis, and protection from the further injury, and nothing else. In case of a damage control surgery, so the basic principle is that the control of a physiological parameter is more important than the anatomical parameters. Like the control of hemorrhage is going to be a priority other than the correction of the anatomical structures. Like if there is a hematoma around the liver, there is a initially the liver, there are multiple packs or mops are placed around the liver to reduce the blood loss. There is a temporary closure of the abdomen. The patient is shifted to the ICU. There is a correction of the coagulopathy, or resuscitation is continued. And if after stabilization of the patient in ICU, the patient is has to taken again into the operation theater after stabilization, and then there is a correction of the anatomical structure. So in case of a damage control surgery, the priorities are control of the hemorrhage, control of the sepsis. The physiological correction is more important than the anatomical correction in case of a damage control surgery. The damage control, the more detail about the damage control surgery will be seen in the trauma section. So the another component is a permissive hypotension. So because the patient is in shock, there is a low BP. So we are going to give a large amount of fluid to increase the blood pressure. but actually if the bleeding is continuously there, we are giving overzealous amount of fluid, it will increases the dilutional coagulopathy and hypothermia and ultimately causes increase in the blood loss. So there is a concept of permissive hypotension. So in due to because of the permissive hypotension, there could be decreased blood loss. So target mean arterial pressure for the permissive hypotension is mean arterial pressure could be around 50 millimeters of the mercury. So just to palpate or to maintain the palpable central pulse. What is the mean arterial pressure? Mean arterial pressure is the diastolic BP plus 1/3 of the pulse pressure. So there is a concept of permissive hypertension to avoid the increased blood loss and to the avoid the dilutional coagulopathy. Target mean arterial pressure is just above the 50 mmHg. So the third component of the damage control resuscitation is the avoidance of the dilutional coagulopathy. As we have already seen, it is to avoid the excess overzealous fluid transfusion like a crystallite. So that could be avoided. If there is availability of blood is transfused in the ratio of 1:1:1 of all the components like PRC, Pepi and the platelets to avoid the dilutional coagulopathy. And the last component is the treatment of the existing coagulopathy. So this could be treated by the injection. Tranexamic acid is given to the all the trauma induced hypovolemic patient. It is given as a 1 gram over 10 minutes with and repeatedly given for a 8 hourly, and ideally it should be given within 1 hour of the trauma. Maximum it can be given up to the within 3 hours of the trauma. And the indication for giving tranexamic acid in case of a trauma is if the systolic blood pressure is less than 110 millimeters of the mercury and the pulse is more than 110. Other components for the treatments of the existing coagulopathy, for transfusion of the cryoprecipitate, the platelet transfusion and the FFP transfusion will causes the treatment of the coagulopathy. So this is the most important part in case of a damage control resuscitation. Remember the 4 key principles of the damage control resuscitation. One is the rapid hemorrhage control, second is the permissive hypotension, third is the avoidance of the dilutional coagulopathy, the last one is the treatment of the existing coagulopathy. So on damage control resuscitation, the short answer question, that is SCQ, could be asked on the damage control resuscitation. So this could be the your answer for the damage control resuscitation. So the another question can be asked in this section is how you calculate the amount of blood loss during the surgery. So these are the approximate parameters to calculate the blood loss during the surgery. So the clot size of a cleansed paste, this amount of clot is going to be of a blood loss of about 500 ml, and if there is a closed tibial fracture, the blood loss could be around 500 to 1500 ml. In case of a femur fracture, the blood loss could be approximately 500 to 2 liters of the blood. And there is another method during the surgery, the weighing the swab or mops before and after the use, and this could be calculated by the Raines factor, that is total amount of blood loss is equal to total weight difference of the mop into 1.5 5 or 2 in case of a larger wound. So this is the range factor. Range factor. And the another method is a percentage of the HB, that is the fall in the hemoglobin, PCV, the hematocrit value. The blood loss can be calculated by decrease in the central venous pressure or the pulmonary capillary wedge pressure. So these are the some parameters to measure the blood loss during the trauma or a surgery. So in the some principles or a local hemostatic agent used for the control of the bleedings are gelatin sponge or a gel foam or a Surgicel. These are the oxidized cellulose. Then microfibrillar collagen powders, the bone wax, and the topical EACA and the topical cryoprecipitate can be used, and the topical thrombin can be used. These are the local hemostatic agent used during the hemostasis during the surgery. So this is all about the hemorrhagic shock. So remember, the most important in this chapter is the damage control resuscitation, the 4 key principles of the damage control resuscitation, and this chart. So this is the chart is important, the classification of the hemorrhagic shock depending upon the amount of blood loss. So in the next chapter we will see about the septic shock. So thank you so much and all the best.